Well, welcome everyone. I'm Kathy McGuire. I'm your host for today, and you have joined the Bringing Care Home podcast. With me today is Dr. Jon Bloom. For those of you who are regulars, you may recognize Dr. Bloom from a podcast on our Slice of Healthcare network back in 2022. But Dr. Bloom is the CEO of Podimetrics. And he's here to talk to us about this exciting technology and services that they have put together. And let's just jump right in. Dr. Bloom, you know the drill. Tell us and tell our audience, especially for those who haven't met you here before, kind of how you got started. Our audience is always thrilled hearing the paths of entrepreneurs, especially when they hear that you invented something in your dorm room or in a study carrel with 5 other guys or whatever, It's always really cool to hear that stuff. So tell us about your path to Podimetrics.
Yeah. And by the way, Kathy, thank you so much for having me to get a chance to chat about this patient who I think often gets ignored by a lot of how we build our health system. I'm just really thrilled to get a chance to talk about it. So my background, definitely not the most linear. I started off as a rather not great punk drum musician. That thankfully didn't last too long. Went to medical school and then went to Mass General for anesthesiology. And then instead of going right into practice after that, I was hired out by Covidien, at the time, a big device company, to be their global medical director for the monitoring division, just trying to think about monitoring systems that could be interesting. Worked briefly at UPMC, and then, finally now, hopefully the end of my story, came to MIT to try to get a business degree, to learn this language that I found myself in. It's so interesting as clinicians, we now hear things like NPV, and I would almost get hives when I heard these phrases. And so I felt like language school. And then in the second month, maybe the beginning of the third month of school, there was a hackathon event. It was just a weekend where you could meet up with 99 other interesting people. We would start companies in healthcare, and I sat down at the table and we decided we wanted to end amputations. And that was now about 13 years ago, and I've been doing that ever since. Again, I know that's a long story, but that's...
Hey, when did you last hear a bunch of punk rockers talking about amputations? I mean, come on.
I used to have
That's really cool.
Cool things with it, but those days sadly are no longer here. And
well, I think it makes you the well-rounded guy that you are, right?
Maybe, yes.
I'm sure that's why you're friends with Jared as well.
We're almost twinsies, almost.
Exactly. So you're sitting around with a bunch of docs and business people and saying, hey, amputation's got to stop. What are we going to do about it? And so tell us about Podimetrics. What came out of that? Tell us, the technology, the services. What did you build and evolve since, really in these 13 years?
I think one of the most interesting things is our first ideas were actually terrible. The business model didn't make sense, which is clearly an important part to create a sustainable business. Our ideas on technology, thinking in terms of, back then we were this insole platform, those had real challenges as we actually thought about usability, as we started to just test some of these ideas. And then, with the way medicine was being operated back then, where value-based care still was not a huge thing. It was challenging to figure it out. But what was really cool, what we did, what many teams don't do, is we just kept working on it. We just kept in class, meeting up afterwards. And what we started to recognize is that this was, first of all, just to talk about this patient a little bit. When I was practicing, and certainly when I was training, I could spend whole days in the operating room doing nothing but amputations, a full schedule of losing limbs. And unfortunately, on this patient, we spend an inordinate amount of direct expenses. And the 5-year mortality after an amputation is over twice that of all cancer combined. So it's about 60 to 70%. It's an absolute killer. And it's devastating our most vulnerable patients. It's typically Black Americans, Hispanic Americans, Native Americans. where you have gaps in access to care. As we think about the home, you can start to get a sense why that was a key spot. But access and engagement were challenges. This is a patient typically overwhelmed with their care. If they have diabetes to the extent that their limbs are at risk of amputation, typically they have hearts that are affected, lungs, kidneys. So it's a complex patient. And just to presume that they'll use this thing every day, I think we recognize that was going to be the biggest problem to solve. It wasn't actually amputation. It was trying to figure out usability and engagement. And what we ended up creating, I hope I'm taking too long on this question.
No, please.
But just give me cues. I take cues easily.
You're good.
We built a mat. That form factor, although not the sexiest, it made sense to them, right? Or like as we started to work with our first populations, like we tried originally all these different form factors, but that form factor seemed to be kind of logical. You put it by the sink, and while you're brushing your teeth, you go on with the rest of your day. That's it. It's fairly mindless. And then we can take thermal data from the feet, which is going to allow us to look for signs of tissue breakdown. Like as you get a sense, if you get a scratch, it starts to get red and inflamed, and it gets hot. That's the extra blood flow coming to the area to try to heal it. We see that spike in temperature and wherever it's occurring on this full two-dimensional scan of temperature to try to see if there's a potential wound that's developing. And the primary antecedent, the primary thing that causes an amputation is a wound. It's a diabetic foot ulcer, this break in the skin that can get infected and get ischemic, meaning not enough oxygen there. And we can see that on the scanner. And then we have a team of mostly nursing staff that actually now tries to work with this patient so that they, in the moment that there's a problem, we can give them the support that they need to try to ensure we can get the prevention that we hope to have. And I can talk maybe a little bit later about our clinical data, but that is where we landed. And we've been able to now get it into, we're now in every state except for, I think, Alaska, now across the United States.
Well, when I think back on my childhood, and my grandmother's best friend, Margie, was a lady who had a whole bunch of different health issues, but she was diabetic. And as a child, you don't even know what a diabetic is. But what we knew is that when we were, 8 and 9 years old, Margie lost her toe. And then when we were 11 or 12 years old, Margie lost her foot. And then she lost her leg below the knee. And then she lost her legs above the knee. And by the time my grandmother and grandfather had their 50th wedding anniversary, their maid of honor, Margie, was in a wheelchair with a double above knee amputation. And it was all about diabetic ulcers. And it was a long time ago because, I'm not as young as I look, but this was, you could see the trauma that people go through. And as you described, this is the biggest kind of outgrowth of a myriad of complex medical conditions that kind of stem from their heart disease and kidney disease and their diabetes. So, wow. And so you've created this mat, and you started to see that you could find problems early and intervene. And so what did that look like in the early days when you were kind of developing them? What did that look like? How did you turn that into a product that, folks were saying, wow, let's figure out how to use this. And I know it wasn't a one-step journey. It takes a long time to kind of turn a boat.
By the way, I think in the beginning, one of the biggest changes we worked through is we kept thinking we were a med tech company. We built the mat, and it was all about how many mats can we create and how many can we get out into homes. And we actually realized it's this great relationship backed by good data that was the real backbone of the company. We started switching to patients we can care for, and as that nursing team built up across the U.S., that was a quite a substantive change to just how we were able to lead to the outcomes that we wanted. And I'll run through a couple studies, but I'll try not to snow you with too many numbers. Probably our first big study was a 7-center trial where we followed patients for a period of time, and we didn't actually turn on this temperature algorithm. We just saw in the beginning, right? You're just trying to understand how good is a system, you see who ulcerated and then which patients we alerted. And what we found is that we were actually able to detect 97% of these wounds a little over 5 weeks before they happened or they presented, 37 days on average. That was the first study, which is just exciting that this, as we tuned the algorithm, it was good at detecting these wounds early. But probably the most exciting paper we had that's in the peer-reviewed literature was our pilot with Kaiser Permanente. And there what we saw in a population in the mid-Atlantic region is, it's a complex patient that we first prevented 71% of amputations, which was stronger than I think we expected or initially to see. Almost 3 out of 4 of these to wipe off the books, but we also saved approximately $12,000 per patient per year on average. The average savings was $12K. Whether we were able to get you to support you for just the first day and that wasn't your thing, or every day in that year, that was the average part. And that was driven by a couple things. The biggest one was keeping you out of the ER and out of the hospital. So we dropped all-cause hospitalization by 52% and all-cause ER visits by 40%. And the idea that they can not have to come to us in the healthcare system, that we can go to them in their home and they can have the life that they want to and not have to be constantly in and out of our system. It was the best. It was an exciting outcome to get to see, and it was the basis of the business that we've built up.
Neat. And so you started to see that it wasn't just a product, it was a product and the data that gets generated from the product. And then it's the notification. So it's a kind of a, product data service. And so how has your kind of messaging evolved around Podimetrics related to that? Because it's not just a pad anymore, right?
Well, certainly when I was at Covidien, my first mentor in this space, he would always say, like, look, a monitor alone is useless. It has to be a monitor tied to an intervention, and only outcomes matter. You don't want to just say, hey, this patient's in trouble and can't do anything about it. Like, you need to know that the alert has something tethered to it. So we really had to build up and validate our clinical protocols, essentially offloading protocols, and how we work with this patient. And then you look for the outcomes. So you have the monitor tied to the intervention to see outcomes. And I think as we started to pivot from device to patients, it really became about how do we create access? This is a patient that's Medicare, Medicaid. It's still a large commercial population, but it's largely these government programs. And how can we get to them? When the biggest challenge, by the way, was that what we kept being told in the beginning when we founded this company, everyone said it, prevention doesn't pay, John, which is cynical. But in a fee-for-service world, that's kind of correct.
Yeah.
Right? And so that was devastating. Like, this thing has to exist. And we really struggled there in the beginning until we started working with the payers to say, look, we can save you $12K per patient per year. Now, capitated providers, to try to keep this patient out of our facilities and hopefully safely in home.
Sure. Well, and I was when you said doesn't matter when if you don't have the right payment mechanism. We've said a long time, whether it's PACE, hospital at home, form follows finance, right, in the fee-for-service world, and you're here kind of banging a drum for a form to follow function, and when you can make a change like this, you want to scream it from the rooftops, and so the payers started to take notice from the data. Sounds like,
yeah, and they're conservative by design, and appropriately so. It's so important that we put our resources to where it drives outcomes the most. So often we'll need to repeat those studies in their populations. But the exciting part has been consistently strong, and we can build up our programs and then start to scale into these programs. And to get to see the needle move, real time is getting to be excited. Now at our scale, you get to actually see the numbers start to move, and it's been
neat. Now for those who are clinically, not kind of thinking ahead with you, all diabetics with certain specific clinical traits that say, hey, this is their next logical step, or do you wait till they get the first DFU? How would a provider decide, this is my population and this group of that population is going to be using these mats?
It's such a good question, and we have to be super appropriate where we place, various resources. There's now, and I'll skip ahead. There's now 4 randomized control trials, 3 of which funded by the NIH, that have looked at a few different populations, and probably the 2 that are now most valid. Certainly, the one that has the most signal is anyone who's ever had a history of a foot ulcer or a partial foot amputation at any time in the past. So it could have been 10 years ago, or it could have been last week. The most data is there. And then the second population that's been validated is patients with foot deformity plus neuropathy, meaning they've lost their body's alarm system. They don't feel when they pick up damage. And that foot deformity is placing abnormal pressures at certain locations and abnormal shear force, even friction force, that can raise the risk of that tissue breaking down. You've lost your alarm system. You have a focus of stress. And unfortunately, that population is also at risk. And then outside of that, I mean, it stands to reason it would work. But I think if we're going to use our resources where it's backed by most data, those are the 2 populations that are most in need.
Excellent. So kind of like your fire alarm doesn't work. Somebody's got to stay up all night and watch for fire. So this is the way that you watch for that fire.
That's right.
Neat. Well, and so the fact that it's being NIH funded right now would suggest that for more research would suggest that you're starting to get a lot of attention, and somebody's saying, hey, these could be big numbers when we think about the saving of feet, right? The dollars are about the payers, but the toes and feet and ankles and calves are about real people and their families. So that's why you're here, right? That's what it's all about.
It's always been challenging because I just don't think it's been as well recognized. So NIH really started to get involved, I'd say, in the early 2000s through to maybe 2007, 8, 9, somewhere in that latter part. And now it's just really about recognition of a patient who we commonly doesn't get the same level of press or note, and just, this is a patient population that's just getting devastated, right? It's where I think as a healthcare system, we haven't necessarily done our best work. Here's a great example of this, by the way. Oh, it's kind of cringy too. When I trained, this is a patient we would often label as poorly compliant. What we were signaling to other docs is we were giving a report that we might prescribe a medication, but it wasn't used. And as I think about just the language of that what I'm saying is that they aren't complying with us. It often is completely ignorant of what's really happening, that this patient may not be able to afford that medication, that it was a completely unusable medication or system, that they could have the transportation. There's all these things now that we recognize social determinants of health. Compliance, it really has nothing to do with it. We've come a long way, even since since we started Podimetrics, and now to get to see it, starting to get into more Medicare or Medicaid, it's been rewarding. We still have a lot of work to do.
Yep.
Don't get me wrong. Sure. Oh my gosh.
Yeah.
But it's been a good run, certainly over the past few years for sure.
That's neat. Well, so as you're you continue the research, you got this thing moving. You've got a lot of funding, so you got momentum. In the meantime, real people are getting cared for here. On the clinical side, how's the uptake? Do you find that it's the payers that are driving this? Is it wound care centers? Is it home health companies that have remote patient monitoring and say, what are we doing for our diabetics? Let me add this tool, and I want to manage it myself. Or a wound care center, we're going to manage it ourselves. So for some people it's the mat, and for some people it's the mat and the data and the alarm going off. Or for some people it's, I'm going to get the mat and I'm going to look at the data and I'm going to be the notifier. What's your combination, or is it really one size fits all?
Well, the challenging part is that there is no fee-for-service mechanism to describe where tech-enabled services have gone. And it's this mixture where you can take capturing of data through hardware, the tech stack which can make meaningful inferences, and the services to deliver it. There really isn't a pathway there. So it's about value-based care, which has been, by the way, exciting. As Medicare Advantage, Managed Medicaid, as these programs have come up to really ensure that you now have, here's a pool of money, let's use our resources in the best way possible. It has really created access, which has been, was a big, that was in the very beginning, Medicare Advantage was really coming up, but it hadn't, where we seem to have gone in 10 years. It's been really exciting.
So, there are lots of organizations that are risk-based, yes. Right? They're risk-based. Yes. They may be they may be a large health system that has its own ACO, and so they're at risk. Is their choice that they buy the product and its services from you guys, and you do all the work that you do now? Or do some of them say, hey, we've got this big remote patient monitoring platform. We want to add this as another tool, and we love your protocols, and we want to do all that. I'm not trying to make you change what you do. I'm just wondering, for the people in the audience, what does it look like to them when they've got some kind of tools in their toolbox?
The people who really help drive this, so it's certainly the payers or anyone who is at risk. Could be capitated provider groups, certainly a huge increase as you think about ACO reach and these new programs. Podiatry have been amazing. Wound care centers. It's just trying to get whoever's, podiatry really is the one on the front lines caring for this patient, which has been important. And we really have, as we've built up this holistic program and approach, what's been important for us to make sure everything is aligned well. So we haven't broken it apart. We want to make sure we're delivering outcomes, and those outcomes deliver savings to payers, which we can, if we're successful, we can share in the savings that we create, which is how our engine works. And key pieces, you mentioned remote patient monitoring. The system, by the way, was not designed to be super consistent with RPM. That was a big change a couple of years ago when we had this explosion of RPM that would get paid. The only challenge to me is, I think it was unfortunately a little bit unintentionally silly in its implementation. It basically said, doc, you need to look at this data every month to get billed. But a computer does that passively. It could just notify you when there's a problem. All that is just silly, busy work. Why would we be forcing docs to look at all these blood pressure measurements and temperature measurements, when instead what we do is just notify them when there's an issue? There's no dashboard to have to look at. The provider should do what they should be wanting to do, as opposed to being like legally on the hook for some dashboard that they better be aware of whatever's on that thing. We can notify them when there's an issue. And I found that has been, you give a clinician anything extra to do, and often that is not a tolerable change. Instead, if you help support them in what they want to do and be in a way that's, the right moment at the right time, we have found that to be a very important piece. It's funny. I think RPM had the best of intentions, but it really leads companies astray in terms of how you can build a sustainable business. Especially
another distraction for physicians who want to understand what's the action I need to take based on the metric that we see right now. And then they might say, okay, let me go and see a trend. But that's something, you're right. They don't need another click on their EMR or on, another dashboard. They need alerts and that are meaningful, that they actually have to take an action for, not just that alert fatigue that happens to them in EMRs every day.
Totally.
Wow. So go ahead.
I was just saying, it was so funny. I used to spend a lot of time in the surgical intensive care unit. That was all I ever wanted to be, was an intensivist back in the day. And you constantly hear alarms going off. It's a ventilator bucking over here. It's a low blood pressure over here. And then you look and no one is jumping at all these. You get desensitized to this constant alarming, called alarm fatigue. And so you really have to be careful to really move the needle. It's that right alarm at the right spot, so that you're not just constantly bombarding our clinicians, our staff with, you just get desensitized to the constant.
Right. Yeah. Well, so, and one kind of audience that we haven't talked about today is the actual diabetic patient. What has been the response of patients and families? As you said, there used to be this, hey, this guy's not compliant. He's never gonna, he always wants to wear these sandals. He's never gonna wear safe shoes. Instead of kind of blaming the patient, you figured out a different way. What what's been the response of patients that are using this on a routine basis?
The most important part is long-term engagement, which means they get it and they want to be a part of it and they understand the value and that it's been a positive experience. And we do a lot of work in the VA. My dad's a veteran with diabetes, and it was just important for me to start there in a population that has very high rates of diabetes and amputation. And there, about 70-80% of our patients who start in the program are still using it near daily at the end of 1 year. That's one of my most important stats, that we're able to keep these patients. Another study that came out recently suggested that for every 23 patients we onboarded, one life was saved within 12 months. As we think about how many patients we have, how many patients we've been able, at least that it suggests we could have saved, and we think about the families that care for them, to give them their independence and their hope and the community impact, it's been quite dramatic. And I think that's been granted, I'm being a physician, I'm maybe a little heavy on studies, but to me, that's the best way to really understand what impact it has, and so that we work with payers that we appropriately place technology and services to the right patient.
And these patients are so chronically ill and challenged to begin with. Now give them a foot amputation or a toe amputation or a leg amputation, and now you've changed their functional status even more. Just to avoid that is a really big deal.
It's their independence. And there was a couple of surveys recently I asked, what do they fear most? Is it mortality? It's often loss of limb, as they realize that they are now often, they could be wheelchair bound either for a period of weeks or months to potentially indefinitely. And that to give them their hope that they, first of all, you don't have to lose a limb. You don't have to, I get that current system can be quite caustic, but that we can give you a chance to stay on your 2 feet to live the life you want, I think has been a huge part for why we've been able to be successful. And I think it's just on us to continue to deliver good care, and that creates good savings, and that drives the business.
Excellent. Well, so tell me, what's next for Podimetrics?
It's really, I feel like a broken record, but it's so true. It's access. We got to get into more homes. We have to be able to offer, I spent time last year in Jackson, Mississippi, for example. There's these regions that have, the infrastructure is just not the same that you have back in, where I grew up in San Diego, for example. And we have to be able to get to these regions where they may be more remote. So how do we get them access to a home monitoring system so that they can stay, ideally where they want to be and not have to come track me down in a hospital later, which is a sign that things have really gone poorly. And I think that's the name of the game for the next, we have good data. It took us a while to really figure out how the system really needed to work. But now that those things are coming together, access, got to get it to the patients so we can, hopefully, we'll never put an end to amputation, but that we can start to give patients their best chance to keep independent. And like I said, that 5-year mortality of amputation is 70 to 80%. It's devastating, or 60 to 80% depending on the study. And that's crazy that that's the case.
Yeah. Well, one amputation is one too many, right?
One too many. Yeah.
One too many. Well, so, this has been amazing. And I think that when, for the payers or the at-risk providers, the ACO leaders, or the clinicians in our audience right now, how do they get a hold of you?
Probably the best way is our website, HTTPS. Always got to remember that part. And it's www.podimetrics.com. It's the best way to do it, and we'd be thrilled to help support any population in need.
Excellent. And I can tell you that the website's great. It's got a lot of great information. It's got a great video and a lot of, read the news, read the, Podimetrics in the news as well, because it'll talk a little bit about some of those studies. And it sounds like you've got really good stuff going on. Dr. Bloom, thank you so much for joining us today. And we'll look forward to hearing more about Podimetrics and the great work that you're doing to prevent problems of diabetic foot ulcers.
Kathy, thank you so much for having me.